Welcome to Dare to Know, interviews with quality and reliability thought leaders. I'm Tim Rodgers, and today I'm pleased to be joined by Dev Raheja. Dev is an internationally recognized consultant and educator with expertise in risk management, quality, safety, and reliability in healthcare, medical devices, automotive, and aerospace fields. With over 25 years of experience as a consultant, he is the author of the books Safer Hospital Care, Strategies for Continuous Innovation and Assurance Technologies, Principles, and Practices. He's taught safety and reliability courses for the Society for Automotive Engineers, University of California, George Washington University, the University of Wisconsin, and in several countries all around the world. Dev is an associate and advisory board member of Standards Associates LLC. He trains hospitals on the science of patient safety and quality assurance. Prior to becoming a consultant, Dev worked for GE Healthcare as QA manager and at Booz Allen Hamilton as risk management consultant. He was a consultant to General Motors for 17 years. He served as an adjunct professor at the University of Maryland for 5 years in its PhD program for reliability engineering, and currently teaches an online course, Quality Improvement Methods in Healthcare, as an adjunct faculty for the BBA degree in healthcare management at Florida Institute of Technology. He's a member of the American College of Healthcare Executives and the American Society for Patient Safety Professionals. He's certified in Six Sigma and in Healthcare Failure Mode and Effects Analysis, or HFMEA, by the Maryland Hospital Association. He serves on the Patient and Families Advocacy Council of the Johns Hopkins Hospital and participated on their quality and safety research group meetings for 2 years. Dev, welcome and thanks for joining us.
It's my pleasure. Thank you.
Oh, it's our pleasure to have you on. This is a very interesting topic I think our listeners are really going to enjoy. Dev, at RAMS 2015 last year, you moderated a panel discussion titled System Reliability, the Critical Requirement for Safe Patient Care. And of course, your books, Safer Hospital Care, which I mentioned before, and Preventing Medical Device Recalls, have been very well received by the medical community. Let me begin by asking, how do we define reliability in healthcare? And specifically, what constitutes good or acceptable performance?
Yes, in fact, we have a very clear guideline on reliability because there is an institution called Institution for Healthcare Improvement, and they primarily focus on reliability. And their definition of reliability is failure-free performance over time. That makes a very good sense to me also. Now, when I say time, it's not 1 week or 1 month. It's a long time.
Right.
At least like a year. So this definition is very simple to understand. They are promoting it heavily. Only problem is that they don't give methods of improving reliability. Their main method is usual collect statistical data, find out problems, solve the problems, fix the problems. So they don't have tools like failure mode and effects analysis and things like that. And so, but they've done a good job of acceptance of reliability definition. But hardly any hospital is there yet. A few hospitals have done a good job in achieving reliability in certain applications. But 90% hospitals still have to learn about it. So here's another definition of reliability. It's proposed by the former head of AHRQ, which stands for American Association for Healthcare Research and Quality. Mm-hmm. And they define reliability as giving the right care, the right way, at the right time. And they define reliability and quality the same way, but the definition fits reliability perfectly. So that's the definition we should go by, but it's still not a wide acceptance of this definition yet.
I like that definition. I think it makes a lot of sense. I'm sorry, you said the right care at the right time, and
The
what was the
right
other?
way.
The right way. Right. You know, when I think about reliability in a hospital setting, I think immediately about fatalities. But I guess you could consider infections to be another kind of defect in a hospital environment.
Oh yes, there are more than 100 types of defects. The most popular ones are, yes, the wrong medications and wrong surgery on the wrong part, surgeons leaving out knives and forks in the patient's bodies, but infection and wrong medications, and those are the most common defects. And third one is a wrong diagnosis. 10% patients get wrong diagnosis,
Wow.
and that means they are going to just die sooner or later.
Well,
So there are a lot of defects, and you can call them a reliability defect. Some people call them quality defects.
right.
Some call them safety. But reliability defects is defect, whether it doesn't matter what we call it.
I agree. And we've been talking about the impact to the patients, but certainly there's an impact to cost as well. I think thinking about operating expense at a hospital or a clinic as a result of these kinds of defects.
Oh, yes. Well, actually, it's a sad story. About 3 years back, a study published in New York Times, it was done by Boston Consulting Group for hospitals, and they reported that the hospitals that made most mistakes also made the most money, most profits. And so it's a goal, it's a situation where there's not much incentive for hospitals to prevent the problems.
Wow.
Because some will have to shut down if they prevent the problems because there's not enough income.
That's
And
surprising. That's
guess what? The
surprising.
managers are measured on profits in it.
Boy, that sounds really backwards to me. You know, Dev, most of us are pretty familiar with hardware products, but as you've been saying already, healthcare is a very different environment with different expectations and requirements. What are some of the principles that we're familiar with in reliability engineering that you've been able to apply in the world of patient care?
Okay. Actually, I have been successful in applying almost any reliability tool I learned in hardware in healthcare. And like, for example, failure mode and effects analysis. That's a very popular reliability tool, as we all know. And the Joint Commission, which accreditates hospitals, it's an agency that certifies hospitals. They have just come up with a new rule about a year back that all the hospitals will have to use FMEA at least once a year on a critical process. Okay, again you can see the problem. They say at least once a year, at least once a year. So what are the hospitals going to do? At least only once a year.
Right.
Unfortunately, that's happening. And then those who are doing it, they are not necessarily doing the right way. They are doing there because it is required by the law to do
Right.
it. So they just fill up the paperwork. So,
Yeah.
but the tools can be used very effectively because it's a tool says take a surgical process, for example. Take each step in the surgery, say what can go wrong. And that's not so difficult to do it. Just
Right.
brainstorming what can go wrong and come up with the solutions to prevent this from happening. And so it's a very simple tool. Now, luckily, the VA hospitals are all using it. They use almost on every process. But those are the only hospitals using FMEA religiously. And fault tree analysis, they should certainly use that, but they are not because they are using typical Six Sigma tools where they use fishbone diagrams. And if they use the fault tree analysis, they could do the same thing but much better. So, yeah,
Interesting.
So I've been able to apply all these tools to all the hospitals, almost any reliability tool you can think about, including redundancies and fail-safe features designed for reliability. Like taking an example of design for reliability. Okay, a, a anesthesiologist gave oxygen to the patient instead of nitrous oxide, and he made this and surgery useless because the
Sure.
patient was awake during the surgery. He was almost dying because of
Wow.
pain.
Wow.
Now, the reason it happened because the maintenance technician connected the oxygen hose to the nitrous oxide hose and other way also. And now, if they use the design for reliability techniques, actually they did. The technique is, what do you do when you give interchangeable parts and you don't want them to be interchanged? You make a unique parts, right?
Yes.
So all they had to do was make a unique fitting for each. It's only cost $10, and they fixed the problem forever. Now nobody can put the wrong hose in the wrong fitting.
Ah, I see what you mean. So it's designed. This is basically poka-yoke.
Yeah, poka-yoke, and you can call it design for reliability. You're designing so that this defect cannot happen.
Good.
Uh,
Good.
Go ahead. Yes.
No, no, that's a great example. I guess what I was curious about is, are there some hospitals or clinics that are more open-minded to these kinds of approaches? Are you seeing any resistance in some quarters?
Well, I see a lot of resistance because the hospitals have very less budget for doing anything other than doing what they're doing. So they're always short of budgets.
Yes.
That's one resistance I see. And second resistance I see is that the top management, according to Dr. Deming, the problems happen because the top management doesn't have good policies and procedures. 85% problems are because of top management. And hospitals are using the going other way. They always blame doctors and nurses for making mistakes instead of blaming themselves. So that's another resistance, that they think it's a doctor and nurses need to be changed, not the management.
Yes.
So they think they are providing safety culture everywhere. That's the best they can do.
You know, Dev, at the bottom of your email, I've noticed that you always add the line, "Humans are not the problem. It is
Right.
the system problem." I
Oh,
like that a lot. I think that's great. Can you give an example of a system problem that?
Yeah, many thanks for bringing this up. This is a very important topic. Okay, if you look at the theory of human factors, well, if you look at theory of safety, there are two theories of safety. One is, it says that harm cannot happen unless at least two things go wrong. That's a system safety society theory and system safety theory. And hospitals don't really pay too much attention to that because it's a system safety theory and not a healthcare theory. So they ignore it. Okay, the theory says that that hazard is already there in the system, defect is already in the system, that lets you make the humans make mistakes.
Yes.
If you remove the defect, then humans cannot make mistakes. So human error is just a trigger event, not a primary cause. It's like a loaded gun. If the gun is not loaded, somebody pulls the trigger, there will be no harm done.
Good point. Good
So,
point.
so we have to remove those loaded hazards. So let me give you an example, okay? There was a young woman, only 30 years old, and she had 2-year-old first son. He was in the hospital, and he was under a lot of pain, so alarms were going on all the time, and she couldn't sleep. And so she complained to the nurse, well, can we do anything about the alarms? They're going all the time. Nurse said, sure, we can do that. And nurse, what she did, she silenced the alarms in the room so she can sleep, mother can sleep. And she did another terrible mistake. She went to the nursing station. There are 7 screens control different 7 other alarms in case of one doesn't work. So I don't know what happened to her, but she disconnected all those 7 other alarms
Oh,
also.
oh
And
goodness.
the boy died. Mother did not even know the boy has died.
Wow.
And until next morning, the mother woke up the mother, sorry, your son is dead. And she said, I didn't hear any alarms. And something she did wrong. And they investigated. Luckily, the hospital investigated. They found that nurse should not have shut down all the alarms
Right.
going to the room. Now,
Wow.
now it's a system problem, not a nurse problem, because the system should not have allowed all the alarms to be shut off.
Good point.
Yeah, they should have designed such a way at least 2 or 3 alarms are going on, no matter what. And there's similar example I can give you. That was uh, Dennis Quaid's babies. Okay, and he had twin babies, less than 1 year old. They needed blood thinner. They were admitted to the hospital emergency, and the nurse gave adult dose of blood thinner instead of child dose, which is 1,000 times more thin. It's like giving 1,000 times more dose. 3 hours later, another nurse did the same thing,
Oh,
and so the babies were about to die. Luckily, the mother was got a nightmare. She got up, went to the hospital to see the babies. They were leaking blood all over.
oh my.
And if the mother had not got there in time, babies would have died in 1 hour. Again, is it a nurse problem? No, actually, it was system problem. The reason it was system problem because the adult dose and child dose had identical bottles and identical writings and everything. Only difference was little one was less blue than the other blue. Now a nurse is not going to pay how much blue is blue.
Right.
So the pharmaceutical company made a mistake. They should not have identical bottles for both. And this pharmacy department they store the child dose and the adult dose next to each other, and
Wow.
somebody picks up the wrong dose. So there were a lot of system problems.
Absolutely.
But they blamed it on a nurse.
Yeah. Dev, these are great examples. It's really clear that the systems in the hospital are a cause of a lot of these issues. I wonder, our listeners may be wondering about this too. What can the patient do? What is the responsibility of the patient to help ensure good outcomes?
Yes, okay. That's another wonderful question. Okay, let me remind everyone that president of the Joint Commission, who's the certifies all the hospitals, more or less. He said that hospitals are using outdated tools like Six Sigma. They are good for normal quality control in industrial manufacturing, but they are not suitable for hospitals because it takes 4 or 5 years to collect data and you are fixing one problem at a time. No, and healthcare is totally different environment where the defect means death to the patient.
Yes.
So you cannot fix the problem slowly and wait for data to come in. You got to be proactive, predict what the problems can happen, prevent it right away. So that's what needs to be done. But that's not happening. They're still using old tools and they are not reforming them yet. So the patient has become more or less responsible for his own protection. And so I would say instead of 85% management problems, now it's 85% patient responsibility. And and now what can patient do? Well,
Yes.
one thing patient can do is that uh, be aware of what kind of mistakes are made in the hospitals. Actually, I have a 15 minutes YouTube on video on YouTube. It's about what kind of mistakes happen in the hospitals. The name of the video is safer hospital care, same as my book.
Hmm.
Okay, that's one thing patient can do. Be familiar with the problems and so that they watch out for them. Second thing patient can do is ask the hospital for an advocate. An advocate is a person who watches for the patient. Of
Ah,
this person has seen a lot of bad news, a lot of bad incidences. He can watch out for the patient. Yeah, so, and you can request that hospitals don't charge money for that. And the third thing patients should do is always have a family member with him or her. If something goes wrong, the family member should do something about it. Like for example, uh, there was a she was a doctor. The patient was a doctor. Her her call button fell down at midnight, and she couldn't pick it up. So she couldn't call the nurse. Luckily, her husband was there, and she was screaming for help. And husband came in to see what's going on, and he called the nurse because she couldn't use the call button. So if the husband was not there, she would have died.
wow.
So make sure there's somebody, family member with you, watching you all the time, how you're doing. And if something is changing rapidly, call the nurse. So yeah, those are the things that patients can do. They have to take the responsibility.
Dev, patients really don't have the medical expertise, in most cases. I like the idea of an advocate who can look out for their interests.
Now let me give you one more thing. I I I go into the senior centers, teach them how to protect themselves from these mistakes. Now, so a couple of examples I like to give you that could be useful to you as well as to
Yeah.
anyone listening. Number one, if there's a family emergency like a heart attack, stroke, or chest pain, don't tell the family member to take you to the hospital. People always do that. That's a big mistake because the average waiting time in emergency rooms is 3 hours. Yeah, and if you are getting a stroke, you don't have 3 hours. Or if you're
No.
getting heart attack, you don't have 3 hours. So always call 911.
Ah,
And so if you call the ambulance, the doctor sees you right away. So that's one way you can protect. Another is this wrong surgery on the wrong part. Like my friend's wife, when she wanted to cut the left leg, they cut her right leg. And how can you protect yourself from those mistakes? Make sure. Well, they mark which leg to be cut.
yes.
Same with the eye, which eye to be removed. Make sure they are marking when you're alive, when you're awake. They are not
Yes.
marking when you're going to sleep.
Yes. Yes.
And anesthesia, a lot of them mark in anesthesia when they go for surgeries when the patient is already under anesthesia.
Yes.
Make sure they are marking in front of you.
Yes.
Or
Good advice.
best is you mark yourself.
Yeah. Yeah. That's even better. You're right.
So I teach those techniques. So yeah, but the patient advocates know these things.
Yes. Dev, let me ask you one more question. Do you see any new or emerging trends that are going to improve system reliability in patient care?
Oh yeah, that's a big improvement coming. Um, last about 1 year back, President Obama's advisors on science and technology, they found out all about these hospitals. 400,000 patients are dying each year from medical mistakes, and that's like three jumbo jets crashing every other day.
Wow.
It never gets no. If one jumbo jet crashes, news gets all over the world. But the three crashes happening every 2 weeks in hospitals, like equivalent to that, nobody's getting attention because only one patient is dying at a time.
Yes.
So the president advisors on science and technology got concerned about that, and they recommended to Obama that hospitals must use systems engineering methods to to make a radical improvement. And and basically, systems engineering is about thinking about a system as a whole, not individual processes and all that. And that includes hardware, software, people, procedures, connecting devices, information in the electronic health records, information in the clouds, and communications between patients, family members, and doctors, and communication among all the doctors and among all the nurses. All these have to be integrated into one. That's what system engineering is about.
Right.
So typical method is you look at the broad objectives, make sure you have a you way to measure the total performance of everything happening right at the right time, right way, and including people, and including equipment and internets, all that. And it has to be patient centered. And you'd include not just goal of quality or reliability or safety. You'd include all these performance goals, which is reliability, safety, maintainability, and availability, and patient centeredness and human factors engineering. So it's a big field. So there's a lot to be done yet. That's the biggest change coming up. But some hospitals have started using it already.
That sounds very exciting. Well, Dev, thanks so much for joining us today. It's been a great pleasure. Really appreciate you sharing your insights with us.
Yeah, it's my pleasure. And just a reminder to all, be sure to see my video on YouTube on 10 big hospital mistakes. And the name of the video is Safer Hospital Care. Thank you very much, Tim.
You're very welcome, Dev. I'm glad you mentioned that. If it's okay with you, we'll post a link to that video along with the when we place the recording, so I think that's a great recommendation.
Yes, please do that. I got the copyright of that.
Very good. That was Dev Raheja, international consultant, educator, and author of the books Safer Hospital Care, Strategies for Continuous Innovation, and Preventing Medical Device Recalls. Again, please take a look at his YouTube recording, also titled Safer Hospital Care. This is Tim Rodgers. Thanks very much for joining us.